Well, thank you again. And what we're going to do, I'll go through a simple outline in a second, but rather than hand the slides back and forth, I'm going to drive, and Ned and I are going to trade off. And what we want to talk about is uh, two papers and some work, really. But in practice, this is sort of what we've done with our time during the COVID pandemic to try to think about how, as many people did, what our respective skills might bring to the table to help with combating the COVID pandemic. And so the result of that, we'll see, but it's some simple economics of testing to reopen schools and the economy. And we'll tell you what we mean. But really, we're going to think about a couple of different features, right? And start by talking about the cost of closures and trying to think about actually quantifying this. Then the sort of meat of what we want to introduce is a new approach to surveillance testing that brings what ultimately we think is relatively simple and accessible, but fundamentally changes the cost and nature of testing, and could and has been very effective in safely reopening schools, but potentially other parts of the economy. Then we'll put those two pieces together, try to make hopefully a somewhat convincing argument that this is a solution that we should be thinking about in reopening schools right now. And in fact, we'll show you some good news from Massachusetts, that in fact, this exact strategy has been used to universally test and reopen Massachusetts schools, and then wrap it up with some lessons for future pandemics and other crises. It's maybe not as grand as that, but some lessons that we've had from the process of not only developing some of this academic research, but also trying to deploying it and working with private companies and policymakers to bring it out into the marketplace. And throughout, as always, we like this to be dynamic, and we know we're going to go to questions, but please put them in the chat, and we're excited for a Q&A session at the end of this. I should add, that's a really important piece of this. It's not just a lecture. Okay, if I can move forward. So closed schools. I'm sure this is potentially too near and dear to many of your experiences. I think from a policy perspective, this is one of the most significant costs and difficulties and frankly failures of the pandemic in the US. And what we want to think about is just the magnitude of this and try to start getting our heads around it. But just to start with that, as of March, only about half students in the US were attending traditional school. Fully 50% of students had either some form of completely Zoom or only limited access to a school. I think we've all seen and understand the tremendous cost in terms of actual education, as well as the mental health crisis facing our students, and the fact that this is unequally borne across socio-demographic factors, that it's not equally borne by the rich and the poor, by minorities versus white populations. And lastly, that it's very difficult on parents independent of the direct cost to children. And in fact, thankfully in February, CDC guidance shifted, making clear schools can and should reopen. And what we want to do is, we're interested intrinsically in this question of how can we reopen schools. We also think this is informative as a sort of reflection of the bigger challenges in policy that we've had in combating COVID, right? It combines real budget constraints, incredibly powerful political constituencies, largely missing guidance in terms of what actually to do. And frankly, at the end, you put those together, there's almost a complete absence of the lack of considerations of trade-offs between costs and benefits, that those aren't coming together. And so we're going to try to, in our own little way, ameliorate some of these issues and maybe bring some clarity to this discussion. Okay, so what we're going to do is begin by thinking about just the costs. And I just want to put this in perspective, that the costs of school closures are very widespread and multifaceted. We're not even scratching the surface. If you just look at some of the early estimates, if we had reopened in September, so if in fact schools had gone back in the fall, the average student would have been 7 months behind in terms of lost material, and students of color, populations of color, would have been 10 months behind. Both high levels and unequal. In the last year, we've seen a 24% increase in ED visits for mental health for children. And I think more generally, those are just what we can quantify now. The true losses may well not be known for years. Despite that, we're going to focus on one aspect of this, which we can measure. And what is that? It may be something that all of you understand very well. If parents are not working because they need to take care of children, what are the losses in their wages? That's a quantifiable cost of school closures. And to do that, we're going to actually be able to look at that directly using the American Community Survey. Some of you may know this survey. It's basically a very rich micro-level census data that captures representative household structure, employment, and caregiving, amongst many other features at the zip code level. So it's very granular and extremely useful. And what we're going to do is layer some assumptions on. So we're economists, that's what we do. But I'll note that while these are pretty specific, the estimates are not too sensitive to changing these assumptions. Basically, we're going to have a couple of critical things. What we're going to do is go to the 2019 wage data and ask, given someone was working in 2019, if they had kids in 2020, and we assume they can't work for some amount of time, depending on who those children are in the household structure, what would be the lost wages? And we're going to assume that younger children take a lot more time. We're going to assume that additional children don't take as much time. We're going to max out the amount of time a parent can put in at 40 hours. We're going to assume that the lower wage worker takes on childcare duties within the household. For some specifications, we're going to value non-working hours at minimum wage. And alternatively, for high earning workers, we're going to cap that amount, reflecting the assumption that if you have very high earnings, you might well hire someone else to do this. And if you put those together, it's a pretty striking number, I think. We do this on a weekly basis. There's some different, we can relax and change these assumptions, but our core estimate, if you look at all of K through 12 schools being closed in the US, that's about almost $10 billion a week in lost wages. It's an incredibly large number in terms of the foregone cost of the economy. It's more felt for lower younger children, unsurprisingly. And I'll note that if you change the assumptions, as I said, you can go from $8 to $12 billion, but these are very big numbers on a weekly basis. The other thing that I should note, we've heard a lot, particularly in the press, about the undue burden that's being placed on women. What we can see in the data is that under those assumptions, about 76% of the foregone work hours come from women. So it's very unequally felt across the gender distribution. And this is really the starting point for saying it's incredibly costly to have these schools closed. Even if we ignore the educational role, the simple role for facilitating people's ability to work makes this a very costly closure. So how can we think about ways to reopen them? So with that, let me turn it over to Ned to give everyone one idea we have to try to reopen them.
Hi everyone, thanks for coming, and it's always fun to see some familiar names in the attendees, so hi to some past students that I see. And I'll just say briefly that, when I look at that number, it's big. I don't know if it fully encapsulates the mental health challenge. John and I both have small kids, so I have a 3-year-old and a 6-year-old, and I will say that the costs are high. So this was a conversation that we started to have basically about a year ago, where we started to think, okay, so there's a huge cost from closing down schools and businesses. Is there any way that we can open these things? And the problem is that there are characteristics of this disease that make it hard to do so. And in particular, as everyone at this point knows, the disease spreads very quickly, and most importantly, through people who are asymptomatic. And so the problem is, what you might say is, okay, well, let's just open schools. When someone gets sick, we'll identify that quickly, take them out, and we'll stop spread. The problem is that prior to that person showing symptoms, they could be spreading the disease. And there are other people who aren't even showing symptoms at all who are going to spread the disease. And so what that means is taking that strategy is not going to stop spread, which means it's not going to be viable to open schools. So we started to think a little differently. Okay, well, what if we could instead do something like frequent mass testing? At a simple level, you can think about every person every single day. More generally, as we'll see, how it actually gets implemented is more like every person every week, or every person twice a week. And so the idea then is that you're not just testing symptomatic people, but asymptomatic people. So you're testing everyone. Every now and then you spot that a person has it on a test, even if they're not symptomatic yet. You pull them from the population and quarantine them. and then they can't spread it to other people. And so by frequent mass testing, you're very quickly identifying issues, removing them, and stopping spread. But when we start talking about this, you look at the cost of testing, and particularly standard PCR testing. For every single test, and early spring, it was even much more than this, is $100 or more. So you think, okay, if we're going to test every single person in a school or in the economy every single day, that's extraordinarily expensive. And we'll see that even then it might be worth it, but that's a large bill. So what we need is some sort of innovation that's going to allow us to bring down the cost. Some of you might have heard what are called rapid antigen tests, which was a possibility. We can talk about that in the Q&A if you want. But those have issues of too many false positives and negatives. And so we started focusing on something different, which is called group or pooled testing. And that's the thing we're going to talk about today. So let me just briefly say that we didn't invent group testing or pooled testing. It's something that's been around since the 50s. In fact, it's used today for blood testing of STIs. But what you'll see is we have a few particular insights as to how group testing works in a pandemic that actually make group testing even more attractive in a pandemic. Let me first just introduce the basic idea, and then I'll introduce our insights. So here we're going to get a little bit of math. It's not much, but John gave me the boring technical stuff. I'll try to act excited and make it more interesting. For me, this is fascinating. There are 20 people, let's suppose, in a classroom, and suppose that you knew that they had a 1% risk of infection. So you say, okay, now I got to figure out who's infected because I got to stop them from spreading it. As we just said, one version here is that you test everyone individually. That's going to cost you 20 tests, which at $100 a test is going to be a lot of money. And then there's this clever alternative, which is called pooled testing. And the idea is that you group samples together and test the group. Now, at a very simple level, and to some extent, this is actually how it works. All it is you're just mixing all the samples together. And then if one of those samples has any viral content, then the group sample will have some viral content. And what that means is if one person has the disease, it will be seen as positive, if at least one person. But if there's a negative, then that means that no one in the group has the disease. And that's a great thing because it means that if we go out and find a negative, which in the case that I just described has an 82% chance, then that means that I just used one test and every person in the group is cleared. So it's very cheap. Now, of course, there is a problem, which is I get a positive test. I now don't know which person in the group gave me that positive. And so now I have to retest everyone in the simplest form. And so then that's going to cost me more tests, one original test plus 20 follow-on tests. But the good news is, given this risk of infection, there's a high chance that we're going to get a negative, which means there's a high chance we're not going to use that many tests. And so that means that the expected number of tests for the group is only 4.6. And so suddenly we went from having to pay for 20 tests to only have to pay for 4.6 tests, which is great. There's a high savings. An important point here to keep in mind, and you probably got this intuitively, is that this is going to work better as prevalence falls. And so the idea is that as we have the problem that we don't want to have is positive group results. If we have very low prevalence, then we have a very low likelihood of getting a positive group result, which means we're very likely to only use that one test, which means that we're going to use a lot less tests. Let me just give you an example. Suppose that the infection probability at the time of testing drops from 1% to 0.1%. Well, then what that's going to do is mean that the likelihood that we get a negative goes up a lot. That means that the expected tests drop from 4.6 to only 1.4. And so now we get huge savings. And so the implication here is just that lower prevalence drives more savings. Okay, so this is just a quick graph just to give you an idea that we do graphs, I think. But broadly speaking, you can just see the relationship, which is if you look at the y-axis here, it's the expected number of tests where n is the size of the group. So in the example I gave, it would be 20. On the x-axis is the infection prevalence rate. And what you should just know is basically if you're doing individual testing, you obviously have to use n tests. But as you're using group testing, then the number of tests drop down lower and lower. And the other thing you might note, which I wanted to put in this graph, is that I just arbitrarily chose a group size of 20. You might think, oh, you could be more clever in balancing the trade-offs here, and you might use instead a larger group size or a smaller group size. So if you're really thoughtful, you can actually even get more savings. But most importantly, what you see here is as prevalence drops, it doesn't really matter. You're getting really small numbers of tests. So our main, it's funny looking back on it. It took a little bit of time to figure this out. Once you figure it out, it's very obvious, but it's weirdly counterintuitive. And a lot of the people in labs, schools, whatever, this is just not an insight that's very clear. But once you see it, you're going to think this is very obvious, hopefully. So again, suppose that we have 20 people and suppose that they have a 1% chance of infection every single month. And so suppose that what happens is I say, okay, so what I want to do is I want to test, and I'm just going to test once a month. Well, we already talked about this. Testing individually is going to cost me 20 tests. Testing in a group is going to cost me 4.6 tests. And then suppose someone shows up and says, look, you can't test once a month. If you test once a month, you're going to have a bunch of spread because in the time you weren't testing, people can be getting sick and spreading it. You have to start testing more. And they say, you should be testing 10 times a month, which is about twice a week, which is actually a decent amount in order to keep spread down. Well, what we know is that testing individually is going to cost 20 tests for every time we do it, which is 10 times. So it's going to be 200 tests a month, which again is going to be a huge amount of money. And this is where the cognitive error comes. I think it's very then natural to think, okay, well then testing groups of 20 in terms of group testing, it used to cost 4.6. We're now doing it 10 times. So it's going to be 46 tests. And in fact, that is not true. So one more, John. So that is a mistake. That's, and I'll show you why in a second. The key is that by testing more frequently, the likelihood that a person is positive at the time of test is dropping. That might be not completely intuitive, but just think about it the following way. Suppose that I was testing someone every hour and I had just tested them last hour and they were negative. And now we wait an hour and I test them again. It's got to be extraordinarily unlikely that it just turns out that they had that infection in that hour. So as I break it into smaller chunks of time, they have a lower and lower likelihood of being infected in that point of time. And in this case, the probability of being positive drops from 1% to only about 0.1%. But remember that we already did this math. That means that the expected number of tests drops every round from 4.6 to 1.4. And therefore, testing groups of 20 is not going to lead to 46 tests, but instead only going to lead to 14 tests. And so what that means is that 14 tests can cover 20 people 10 times over the course of a month, which is, as you can imagine, it's extraordinarily high savings here. So just to again restate the logic, the more frequency you use, the lower the probability of being positive at every point that you test. Given the lower probability of being positive, we have higher group testing efficiency, which means you're using lower amounts of tests in each round. One way you could think about this would be something like a quantity or a frequency discount. So it's almost like you go to the store and you say, hey, I want to buy more times a month. And they say, oh, that's great. We can actually give it a little bit cheaper. So you can buy 10 times the test for about 3 times the price. And more generally, for those of you who are math inclined, there are some complicated formulas here and using a particular form of an approximation. It turns out that you can buy X tests, X times a month for about root X, the cost. And so root 10 is about 3, which is how we got to that point. Next slide, John. Okay, just to, again, show this to you in some sort of graph. The idea is as you increase the testing frequency, which is on the x-axis, and you think about the expected number of tests, the idea of this dotted orange line is if you were to just extrapolate and you were just to say, you know, it costs, as I did before, 4.6 tests for every single, if I tested monthly. So I'm just going to multiply that times the testing frequency. And that would lead you to think that testing is very expensive as you increase frequency. But the reality is actually that it's much, much cheaper. And so that's what shows in terms of these concave orange and blue lines. And a key point again is, yeah, you can do optimal group size and get cheaper, but really the most important part is the fact that higher frequency leads to lower prevalence, leads to more efficient testing. Okay, and then I'll say, I'll give, I know that most people have really neat PowerPoints, but we're boring economists. We don't have PowerPoints, but I should put one picture in there. There is some more here, so I can be a salesperson here. So in fact, you might be sold, but there's actually something better. Remember that the reason that we're doing this is because we're trying to get rid of infected individuals. I should say quarantine, remove them from the population in a very gentle way and allow them to return. So what this is doing is by testing 10 times a month, we end up being able to detect who's infected, quarantine them, and then they don't infect other people. So that's another way that we're reducing the probability. So we go higher frequency, that means we get less spread. That means we get even lower probability of being positive, which means even higher group testing efficiency. So taking this into account, testing 10 times doesn't just cost 3 times the cost, but in fact 1.6 times the cost. So in some sense, it's very, very cheap to start to test more frequently, because one way to think about it is just, I'm testing all the time. Given that I'm testing all the time, I'm keeping spread down. And because I'm testing so often, the probability is so low. Given that, I'm constantly getting negative group test results, which means most of the time I'm only using one test. You can see this in the next graph. Pop one more, John. So just very briefly, there are 2 y-axes here. One is the expected number of tests as before. The right-hand y-axis is the infection rate. So if you look at the red curve, that's the infection rate. You might recall that when things are spreading in populations, it's an exponential growth. And so what that means is testing every month is really bad, because you get this huge exponential growth because you're not stopping it. And so you get a lot of infection. However, as you start to test more and more, you're dropping that down to the point that if you're testing bi-weekly, you're doing pretty well. It'd be great if you tested every day, but bi-weekly is doing all right. And now look at the cost curves associated with testing. They're actually pretty flat in that region, and in some cases even decreasing. And so what that means is going in somewhat counterintuitively, testing more often doesn't really cost you that much, because again, you're lowering the spread so much that you're lowering the probability so much that you're increasing the group efficiency so much that it's actually pretty cheap. And that's just that's the main intuition of the whole paper. I'll give one more quick insight into the paper in the next slide. That is that the other thing that's neat here is that you might think, okay, well, who are we going to group together? Well, it turns out we're going to group together people in a classroom or people in a business. And that actually ends up being really useful too. So the idea is, if I, for example, am testing my family, if my kids are sick, as any parent knows, I'm very likely to be sick too. So that's great. What that means is actually it helps group testing. If you have a dorm of 20 people and they have an independent risk of 1%, then as I told you, the probability of this costly group positive is 18%. But if they have perfectly correlated risk, which is an extreme example, but suppose they have perfectly correlated risk, what that means is they're either all sick or they're all healthy. But that's great, because it means that only times that I have to use those extra tests are when it's really meaningful, because everyone is sick. And so in that sense, I actually reduce the cost of group testing. And so overall, what this tells us is this is great. When you're using group testing in a pandemic, using correlated groups and doing it frequently, it's extraordinarily efficient. And maybe we can actually afford to do this. Okay, now I'll switch it over to John to do the final part of the paper in terms of estimating risk.
Yeah, so this is, and I would add that for those of you who want to or have read the paper, it's gone through a bit of evolution. The first 2 points that Ned highlighted are really kind of the key things. And in fact, as we get into the application of this, we focus much more on that. I hope it's been intuitive. It also means that implementing this strategy is not very costly, right? All we're saying is, change frequency. And in fact, sometimes it's an added bonus because lots of places wanted to test more frequently. The last piece, though, I think, we originally focused on, in part because we were getting asked, I do a lot of work, and both of us do a lot of work, applying machine learning tools to large-scale healthcare data. And there's this intuition that if I could predict better, I could target testing better, independent of the pooling idea. And that's continued to be out there. And it's certainly true. But the interesting piece of it is that, actually, remember, knowing risk can help you form better pools. And really, that's what we're going to focus on, saying, well, in principle, you could use some of these tools from machine learning that are so good at predicting particular outcomes and so good at predicting who's going to be risky and correlated risk. You could do that in order to optimize pools. Okay. And that's the last sort of insight, right? The previous research was really based on this independent risk. But we want to basically figure out who has correlated risk and put them in the same pool. And one approach would be just to say that the folks are in the same dorm. And that is this natural mapping to the operations, which is, let's just collect samples where they are, right? Rather than having some complicated drop-off procedure, let's just send someone down the hall or have a drop-off basket at the end of a hall, say for a dorm or in a hallway in a nursing home. But we can maybe do even better, which is we can try to estimate risk directly, right? And the idea is, if I'm more accurate about risk, I can form pools that minimize retesting, right? If I form bigger pools if I have groups of low probability people, right? Remember, if prevalence is lower, I can use bigger pools and the probability of retesting goes down. If I know the risk of individuals, I can put them in their own pools, right? So if there's very high risk people in the extreme, I can test them individually versus other healthier probability folks and put them in a larger pool. And how can we do that? So machine learning really can be used to predict risk as well as to predict transmission networks. So think about both the idea of having lots of data on someone's demographics and zip code, as well as maybe even richer data on social interactions, such as cell phone and mobility data that I have used, for example, and that others are using in terms of figuring out where people are congregating. And this can actually make the approach that we've laid out, which is already much more efficient than the conventional wisdom around testing. It can make it 2 to 3 times more efficient. Okay, and I'm not going to go into too many of the nuts and bolts there, because really at the end of the day, it's all about predicting that risk and how you do it. There's lots of different approaches for machine learning one could use, but I just want to lay out an old plot. This is from the fall, but it tells you sort of, and I'm going to come back to New York a few times because remember, this is the beginning of the pandemic. It's an incredible outbreak. This is also where, if you recall, testing was incredibly constrained. There just wasn't enough supply. And we'll use this as an example, because this was often held up as why you can't do pooled testing, because prevalence was too high, or that why testing is not a solution because we don't have enough testing. We're going to argue, and I'll come back to it, that in fact, this is precisely when you want to do testing. When you need more tests, being more efficient with those tests is more valuable. Well, how do you account for the fact that if prevalence is high, pooled testing is less efficient? Let's be more predictive about who's actually high risk. This is the stock. So this is the total number of cases by zip code in New York. And you'll notice that there's a lot of variation, okay? And so this is simply to point out, if I had a machine learning algorithm, which was basically which zip code you came from, I could much more effectively form pools, right? If you're coming from Corona or Elmhurst, I'm probably going to put you in a very small or an individual pool. But if you're coming from, unsurprisingly, other Upper West Side, other parts of Manhattan, the risk is much lower. So you can use much larger pools and keep using this approach, even though the average prevalence is going up. The heterogeneity in prevalence allows us to keep doing this. And I've had a couple questions in the Q&A about the terrible outbreak in India at the moment. That would be another great example where rather than saying this is when we can't do this kind of pooled testing, it's when you want to be doing more of it because you need your resources. The same token that makes it cheaper, it also means that you're just using less tests, and in constrained, when demand outstrips supply, that's when you want to be using less tests. All right. So if we take this insight and combine it with what I showed you earlier, And so again, and Ned hit this on the head, and I'm sure all of you are way too familiar with this, that the costs go well beyond the foregone wages. But I want to start with what we can measure and just show you the economic analysis of reopening, okay? And we're going to take as an assumption that in fact, if you reopen with the kind of testing we're showing, that you can do so safely. And in fact, the CDC now has agreed with this. And you can see from that simple plot of infection rate that if we're getting to weekly or biweekly testing, that in fact, the risk gets very low. And one might go even further and say, if kids are at home, they're not sitting by themselves. And in fact, there's no testing at home. It may even be safer to reopen school. We don't even need to go that far though. Here, basically, I'm just going to compare that $9.4 billion in foregone wages weekly with the cost of doing weekly PCR testing. So the first, as well as the additional costs of bringing kids back to school. This is work that's going to be coming out in a paper with some colleagues. These additional costs are basically the cost of changing air filtration, other investments needed to reopen schools. But the bulk of it, if you're doing testing, comes in the testing component, particularly if you're doing individual PCR. And this is the numbers that are being thrown around when you hear different policymakers and business leaders saying it's too expensive to reopen school with testing, because they're saying, well, it's $100 a test a kid, okay? Now we might still say, look, the gains just in wages dramatically outstrip that. But what I want to note here and focus on is that in-lab pooled PCR, which looks like what we're talking about, this is exactly the model, takes this down to the actual testing costs per week are around $1 billion a week. So if you said, let's reopen all the schools with universal pooled PCR testing for all the students and staff, you get about a 10-to-1 ROI just relative to the wages that we would gain from having kids go back to school. So, let that sink in for a moment, that the return is very, very high. This is not counting the other costs. And in fact, we're arguably getting a lot of externalities that we're not accounting for here. If we're testing children, we're testing communities, we're preventing spread otherwise. What I'll also note, and we'll come back to this in thinking about, well, what happened in terms of why wasn't this everywhere, that we've also done this for point of care rapid antigen test. And in this, we're holding fixed the effectiveness of screening on prevalence. So why does these rapid antigen tests that have been so much lauded in the media as 15 minutes and cheap cost so much more? Because they're not actually as sensitive. And so you need to do them about twice as much to capture the same amount of disease, to get the same amount of prevention as you need to do with a PCR test, okay? Oops. And so with that, let me turn it back to Ned. We want to talk a little bit about, well, it seems like a good idea. Did anyone actually do this?
I was just in the middle of typing an answer, and I'll just answer it live, which is, as Sandeep says, what does it mean by group testing every day? Does it mean randomly testing one individual from a group of 20 daily, or mixing everyone's test samples daily and testing that sample once daily? It's the latter. The idea is that every single person, so simplest version, and we're actually going to see this happening in Massachusetts, but the simplest version of kind of what our dream was, and like you said, or like I said, you'll see a little bit in Massachusetts. And we thought about this, for example, for Haas. Every single day, every professor shows up. They were given a bunch of kits where they can spit into those kits. They're at home, they spit into one of their kits, they come to work, they drop it in a little giant container. Then all those samples are taken to a lab where things are processed, mixed, and tested. The vast majority of time, that's a negative. Everyone continues to go to work. Every now and then, rarely, hopefully, you detect a positive. Given that you detect a positive, you remove that person, quarantine them, and keep going. And so that was the idea, the kind of ideal thing. One thing that I'm sure all of you are saying right now is something like, oh, well, this is great, in theory, but now what about in reality? Reality is not just the math, but you have a bunch of people who need to give samples. How do they get them? How does it get to the lab? Can the lab actually mix them? What happens in terms of, is it easy to detect the virus in a mixed sample? There's a bunch of logistical things that happen. And in the end, that's what we spent a huge amount of our lives dealing with in the summer and the fall. And some of this is kind of a fascinating story, I think, of academics and trying to understand the real world and frustration of it and what happens in a pandemic. We'll talk a little bit about that. But broadly speaking, I think if you had asked me last summer, is this feasible and could it actually be implemented in the fall? I would have said, yeah, because we were talking to a lot of labs and they said it is feasible. But then for a lot of reasons John's going to talk about, regulatory incentive structures, I think a lot of it got delayed. In the fall, then we ended up having a lot of conversations, and I don't want to overstate our role because we're not in these companies day by day doing the work. We're not in the organizations that were running the pilots. We tried to suggest that this was a good idea. We bizarrely got very good at understanding the difference between saliva samples and nasal. I mean, it was weird that this was what we were talking about in the fall. But you do what you can. But again, I don't want to say we played that much of a role. We played a small role in trying to stimulate the demand side and the supply side. On the supply side, as John will talk about, there are reasons that a lot of the larger companies were very content making huge amounts of money on individual testing and didn't really have a great incentive to try to do something new. So there are a bunch of new companies, a few listed here, who we were talking to, who were thinking, we're going to enter into this market and we can do group testing. We're going to set up our labs to do it, and we're going to do it frequently so that it's affordable, and we can bring the price down from $100 to what we had always thought was possible, which is on the order of $3 to $5 a test, which is much more reasonable. So they started to work together, but as everyone knows, doing something in reality is different than doing something in theory. You got to figure out how to deal with saliva and nasal, all this stuff, but they worked together and did it. Meanwhile, on the demand side, there were a bunch of organizations from cities. So the entire Wellesley, Massachusetts, basically the whole city got together and said, we're willing to try this. We're going to test all of our first responders. We're going to test our schools, and we're going to start using this system. There were organizations we talked to, like independent living centers, which is an aside, a really sad part of the pandemic is a bunch of people elderly people who are vulnerable and therefore were basically kept in their rooms for multiple months. And they said, we need to figure out a way to get these people out. We're willing to pilot this. And then some schools, early out childhood education, who said, we're going to do the work to try to figure out logistically, how do you go get nurses to sample, get people to give self samples, combine them together, make sure that they're positive. So that started to happen in the fall. And finally, things have started to look a little up, as you might think, a little bit late from our point of view, which is kind of sad. I'll put in the chat briefly an article here. So in Massachusetts, basically what started to happen is it was amazing that the companies started competing. We actually got tests. And I will say, as an aside, the companies are also less profit focused and being very reasonable in trying to provide a public service. They got it down to the order of $3 to $5 a test. State started to see these pilots work and said, we'll provide funding for this to get schools back, recognizing the economics that John went through. They gave $40 to $60 million to do a 2-month pilot. That pilot runs out soon and we'll see how things continue. 1,000 schools opted in. 300,000 schools or students are being tested. And now it's getting better and better in terms of the best practices to make this work. And so that was validating in some sense to see, although, as you might imagine, the fact that I think we could have perceived that maybe this was even possible in the fall, it feels a little late, but it's great that it's actually working. And then as a terms of a next step, I'll put another link in. So as John will talk about, and some of you might remember, President Trump was not the biggest fan of testing. And there's a big issue here, which is it's very hard to put the costs on the schools or the organizations. And this is a point where you would hope from a public policy standpoint that someone looks and says, whoa, we're losing a ton of money collectively. What we need to do then is provide public assistance here, public funding to get this testing done so that then we can get the economy back, which will pay us back in the end in terms of productivity. Biden is more interested in that. As you'll see in this article, if you want to take a look at it, he's put $10 billion of testing, and there's this attention on pooled testing, particularly what happened in Massachusetts, and saying, maybe this is a model that we can get things back. And I'll just say briefly that you might think, well, with vaccines and everything, aren't we done with this? Younger kids and very younger kids in particular are not going to get the vaccine for a while. And so this is still potentially an important way to make sure that infections are not spreading through schools prior to them having the vaccine. And maybe even important more broadly in the sense of if we don't get enough people taking the vaccine. And with that, I'll pass it back to John.
All right. Well, there's been some great questions so far, and hopefully this will stimulate discussion, but I want to basically talk a little bit about the broader lessons. And I think the emphasis is this is clearly not close to over yet. And even though vaccines are giving us a lot of opportunity, as Ned said, the trial for younger children will not be done for some time. And there is likely also to continue to need to be testing if we are in communities with insufficient vaccine take-up. Also, frankly, there's a lot of expectation that there will be some testing for surveillance continuing. So this is likely to be important. But I want to just talk a little bit about kind of what happened. Why wasn't this everywhere sooner? And also maybe what we can learn about the interactions of the private sector and the public sector and innovation for other pandemics, which we now know we need to prepare for, as well as potentially other kinds of disasters where technological change is required. Scratching the surface. But so one thing to note that I think has been a big issue here is that testing has been a focus of policy and politics going well back to the frankly unbelievable view that testing was a problem last summer from the administration. But really, from both sides of the aisle and the media, almost all of the discussion has been focused on overall rates or access to testing at all. And it's really never been viewed through the lens as a strategic asset, or very, very infrequently. And I think that's an important feature to think about. Even in vaccines, to some extent, we continue to view it as rates. Now, the good thing about vaccines is that rates and strategy are very highly correlated because you want to get to herd immunity. Though one could certainly imagine even here thinking about this not just as a rate of access, but of basically combating the disease where it's most effective. And I think the other thing to think about, which is important and relates to kind of how powerful, at least in our view, sort of conventional wisdom or simple narratives from Twitter and the like were in the actual reality of decisions. That these initial constraints were real in New York, but then there was a perception that because in New York, when the pandemic took off, people couldn't get tested, that testing and somehow wasn't a solution, because when the rates are high, we don't have enough tests. And that both reflects, it misses misses the potential for innovation and investment, but it also misses the fact that, for example, this very technology could have relaxed those constraints on the order of 10 or 20 times more tests for the same number of PCR machines. And then the real thing I want to sort of think through and just give some musings on from our perspective as sort of academics and practitioners, at least to some extent for the last year or so, is that why didn't we see more of this? And I'll actually frame this as a particular juxtaposition, that why in California versus Massachusetts have we seen wildly different levels of comprehensive testing and innovation on this dimension, right? These are very similar innovation economies. We pride ourselves in having better universities and as many or more biotechs, but you've seen a very different complexion. And that's sort of a micro version of the broader kind of why isn't this much more widespread? And we can think about at least some ideas. As I say, these are some initial discussion. I actually think it's a critical domain for research and preparing for the next pandemic, which will come, as we know, and also thinking about for more broad surveillance, but why and how did we do things well, and why and how did we do things poorly? And the first thing to note is that testing was largely relegated to the states and the private sector for the majority of this pandemic. Now, that's a political decision at the top, but more generally, I think there's reasons, just without getting into the politics, of why that might not be efficient. That there's dramatic externalities that you have from testing. So this is the definite, I'm a health economist. Long before this came around, you sort of say, where in the economy do we have externalities? Well, it's infectious disease. I mean, very clearly, my being infected affects everyone around me. So my private efforts to mitigate disease are going to be too low relative to what society would like me to do. Well, it turns out if you basically relegate testing strategy to private companies, for example, many of whom have come up with fantastic testing strategies, you're going to get too little testing. That their privately optimal testing strategy to protect the company is going to be too little for the communities they're in. And that's really the only place you saw very comprehensive testing initially. Now, alternatively, there's also an important issue of liquidity. So I went and showed you the fact that there's tremendous ROI for implementing these strategies. And probably there was even tremendous ROI at the individual level PCR, right? We're still getting a 2-to-1 or more return on that. In fact, we made this point early on. Paul Romer, for those of you familiar, the macroeconomist, made this point early on, that if the cost of the pandemic is something like 30% of GDP, we should be able to pay for a strategy to test people to stop it. On the other hand, because there was no budget for this, the people actually implementing it didn't have the money to pay for it. That there is not a lot of slack in public school budgets, even if we think that for society, the ROI of reopening them was high. And the third one, which I think is really, really important, is that behavioral and information frictions through the perceived cost and lack of guidance. If you ask me kind of what is the biggest change been that's driven at least some of this, it's examples of what's working, and it's changes in guidance from the CDC. Despite the fact that the FDA and CDC basically said you're allowed to do surveillance testing, there was no guidance on what this means, how it would be used, and why it would be used. And without that, both supply and demand was left with some combination of conventional wisdom and the status quo that they were in, which is doing individual tests that are as sensitive as possible. The other thing that I think is important to think about is a pretty interesting unintended consequence. And we're in one of the states that really was a leader in this, that there were regulation and mandates, in this case from the Newsom's office, to cover testing. So it seems like, and it is a great idea for many reasons, to say insurers have to cover COVID testing, right? If there's a big externality, we want more coverage. The US healthcare system is propped up on private insurance. And so this seemed very effective. But when it comes to innovation to make cheaper and more effective testing strategies, for example, for schools, it actually has a very important unintended consequence, which is insurers only cover the actual PCR tests for individuals. They didn't cover pooled testing, and they didn't cover surveillance testing. So for example, my children's school, when they went into a testing strategy, actually got a bid for pooled testing from Miramis, which was incredibly cheap. That's one of the companies we laid out. And alternatively, they could pay nothing. And the resource cost for doing individual tests where everyone's insurance covered it. And that gives you exactly the idea of why this sort of unintended consequence really pushed schools to not do the kind of surveillance testing that was done in, for example, Massachusetts, where this was not the case. What else happened? And I think this is a more general and interesting question, which is the sort of perfect being the enemy of the good. And I'm a healthcare economist by day. We see this a lot, where the kind of disruptive innovation that is famous in a lot of industries, where I do something a little bit worse, but a lot cheaper, is very hard to happen. It doesn't happen very often in healthcare, right? That there's sort of we know that this is the best possible test clinically, and any degradation it was sort of not perceived as a problem. And in part, this comes from very reasonable norms in the healthcare industry and the lab industry, but it made it very difficult to say you should take this pooling approach, which is a little bit worse in terms of sensitivity and specificity, sensitivity in particular, but a lot cheaper. And in fact, if you do it more frequently, at the population level, it's maybe even more sensitive than doing testing. But that idea from a lab's perspective, which is I have one test and I'm going to do the gold standard on that test, created a big barrier. The other one, which many of you probably have seen in the media, I sort of call it the waiting for Godot issue, which is there were constant ideas and hype coming out around innovation in antigen testing, that we were going to have the 15-minute test. We were going to have the test you take like brushing your teeth. We have them to some extent now. They are still about 10 times less sensitive than pooled PCR, and there's still not enough of them to implement at scale. But I think one reason, and if when we would talk to labs, there was an unwillingness to invest in the technology to improve their existing capital to do pooling, namely invest in a robot to do the pooling, because there was an expectation that these antigen tests were always coming. And I think this is a challenge where innovation around existing capital that didn't have basically patentable results, namely doing pooled testing, got a lot less investment from the private sector than did antigen tests, which were patentable and could be held. And then the last one, which has been a real challenge, and I think this sort of speaks to the role that conventional wisdom plays in major policy decisions, is that there was just this idea that pooled testing doesn't work with high prevalence. And that is correct, but it comes from sort of, as Ned said, this has been around since World War II. It comes from the idea that you're doing one-shot testing of a population. But if you think about all the results which we've just showed you, when you have a dynamic decision, when you get a full strategy, that goes away completely. And then the last point there also, and this really came out of New York, and I made it a couple times, is that precisely when you think prevalence is high is when you need more tests. And so pooling in the approach we've laid out here actually becomes more effective. And I think that was another big barrier that you ran into. So what are the lessons for the next pandemic and more generally? I mean, there are many, many more, and these are probably too broad. But what we've seen is that federal guidance is critical for investment and demand, that even strong state guidance was insufficient to get the kind of investment we needed to get this going. Coordination is more generally important here. And you've seen that, right? What is the major or maybe only thing the US has done particularly well in the pandemic? It's been vaccine development and distribution. And Project Warp Speed is a great example of kind of where this coordination investment was very effective. The second thing I think is very important in thinking about policy, and this goes well beyond just COVID, but we need to increasingly link costs and benefits across domains. There's people tend to view pros and cons in silos. And here you can see if we simply combining the education and the labor market, you actually get a very different conclusion about the costs of keeping schools closed that we can quantify and then relate to the cost of testing and reopening. The third one, and I really hope that this lesson is out there, is that testing and surveillance is a tool for prevention. That this siloed view of testing as a medical technology that you get when you have symptoms to validate or invalidate those symptoms is missing the opportunity to really surveil for disease. This is true of COVID. COVID is likely endemic. We will need to continue to do surveillance for it. But in addition, flu and then the next pandemic, that this should be used as a tool in the public health sense much more than it has been viewed. And then lastly, I will end with that one of the biggest challenges percolating through all of this, and this is not news to anybody, is that a simple narrative, and I would say that this came out on both sides of the political spectrum, can be a huge challenge to derailing change. And we've seen this from, as I mentioned, from the sort of right wing that said testing was a problem in and of itself, and on the left where any conversation about reopening was viewed as supporting Donald Trump. It made it extremely difficult to sit in the middle and say there's a clear rationale for our children, for our economy, to be both reopening and doing a whole lot of testing, right? And that kind of conversation was very difficult to have with a lot of policy folks. I will say that at the end of the day, these ideas that the money in the COVID stimulus bill has really comes in part from some of these ideas that you can do efficient large-scale testing, and that is a key piece of reopening schools. I hope that conversation continues, and I hope we get some of this implemented well beyond Massachusetts, where it's been proven to be a pretty big success. I am cautiously optimistic given the role that these ideas play in the federal expectation and the actual amount of money set aside by the Biden administration. Also because the governor of Massachusetts is one of the bipartisan governors group that has met to basically focus on reopening schools. I think, and I know that these ideas are also front and center for a lot of states. So I will, with that, say thank you all for coming, for spending your mornings, your evenings, your afternoons, wherever you are with us. And let's open it up to questions. We've had some great ones, but certainly want to make this more of a discussion as well. So I will stop my sharing. And please put your questions in the Q&A, yeah. Or the chat, I guess, works. I'm not sure.
John, I'm more amazed that we hit 11:45 perfectly. John and I were talking about how long this was going to last. We had no idea, no insight, and then boom, perfect. We're amazing. That's really the big success of the morning, honestly, for me.
So I do see a question about the pooled testing strategy. In Europe, that has been used in a couple of different settings. Denmark is using it pretty heavily. Europe also has done a lot more testing in some of their reopening. Though the other thing to remember about Europe is until recently, they had it much under control, much more under control. So there was somewhat less of that investment.
They're so clear that we have no questions, or alternatively, which I worry, we were so unclear that people don't even know what questions to ask.
Oh, there's an open question.
Okay, so yeah,
I can, oh, you want to go ahead now?
Yeah, now go for it, John.
So I will not editorialize beyond. So I think the teachers unions have been resistant to reopening well beyond the scope of this, but there's an important piece to it, which is that the unions, in our view, to some extent appropriately, required PCR, not antigen testing. A lot of them, it was viewed as the gold standard. And so that is actually, to some extent, could facilitate this, which is that by doing pooling, you're getting PCR testing at much lower cost. In Massachusetts, the unions have been actually very positive and receptive to this. So Massachusetts has come together a lot more on this, and so it's so I think you have seen that. In terms of our state, or more generally, my limited understanding of the back and forth of the unions is somewhat beyond just the pure testing side. So.
Yeah, I think just as an aside, what happened because we had at some point talked to the government in California to figure out what was going on, and I actually think the timing, again, had this become a feasible strategy earlier, maybe it would have been possible. By the time we talked to them, the unions were much more focused on vaccines and making sure that all the teachers were vaccinated and their spouses were vaccinated prior to the testing stuff. It would not completely surprise me if this becomes an issue for reopening in the fall, that they start to say, well, wait, the kids, the vaccine isn't 100% effective. The kids have not had the vaccine, and therefore maybe we need this. But the last time we talked to them, not surprisingly, the focus was very much on the vaccine.
To what extent is access?
So the issue is not so much the access to PCR testing. I think the issue is that the capacity that we have for PCR testing, given the incentives that John laid out, is largely focused on individual testing. And I think it's because there are very large labs that made a huge amount of money in this process, charging $100 or vastly more for what has a marginal cost of a few dollars. And for them, I think they were very uninterested in doing this. And so you really need new organizations to show up and do it. In terms of then you have just a capacity straight in terms of like Miramis or Ginkgo, they, I think, have the ability to increase capacity pretty quickly. John, is that, I mean, you know, I think they're doing a decent
they're
job.
running up against capacity. So, but I think the issue is converting. There's lots of PCR machines around that have been doing this, and so it was more a question of getting them to make that relatively inexpensive investment. So you could, you know, depending on when you did this, you could make your money back pooling, cover your fixed cost of, in about 3 to 6 weeks. So it wasn't really a barrier. On the other hand, it did require change in thinking. It required investment. And most of these labs were making money hand over fist doing individual testing. You're seeing a shift now towards this. So the biggest news on this is that LabCorp is now offering a school-based pooled testing approach at this point. But it took this massive market shift that took a long time and really was spearheaded to some extent by Massachusetts' shift into it, and the Biden administration basically saying, this is the way to do testing in schools, and we're going to put more money into it. Without that, you didn't see any of that investment. And this is where it comes to both the money and the guidance on what kind of tests should and could be used. So there, I also see a question about China. So that really is, that's pooled testing. That's the same thing. So you could do that. Now, it's not really necessary in the US where we have large scale vaccinations to do that. But for schools, it would be a very good idea. Now, the key thing that, Terry, your question about what China did, that ignores the frequency. And so you're not really going to get much action unless you do this continuously, so that you do it in a population to suppress the virus overall. And that was actually an issue even more generally early on, that if you remember back to those heady days in the fall when people started to do testing programs, almost all of them were monthly because they said it was expensive. And as you saw from that chart, monthly testing is basically useless. It just tells you the horse is out of the barn. And so even if you're doing pooled testing in large scale populations, you need to continue to do that for a protective basis.
And let me just answer. I'll note something that Terry says that in a little bit more detail, which is a complication that comes from, you know, going from theory to reality. In theory, what happens is you test the group, you find it's positive, and now you kind of instantaneously test the 10 or 20 people that were in the group. That is a challenge because it requires that you go and retest those people or that you hold back some of the sample. A much cheaper way to do it, which sounds a little bit like what you're saying, but has costs, is that basically you just test the 20 people. And if it's positive, you just say all 20 people have to be quarantined or deal with it themselves. When you talk, though, when we were doing this, you know, in the fall in Massachusetts, not surprisingly, a lot of organizations, let's say, you know, they have nurses and they say, if you test 20 of our employees and then you tell us that all of those nurses have to go home, we can't do that. We need a quick turnaround. And that was actually, from an implementation point of view, a very hard thing to figure out, is how you can very quickly determine that you found a group that's positive. How do we then quickly turn around? And so there are a lot of different ways to do it. So it's cheaper if you don't have to go through that process, but obviously costly, and some organizations are going to be pretty unhappy doing that.
Susan, you ask a good question. We do get this a little bit. I guess I don't know if it's gratifying or not, which is that this makes a lot of sense. So what can we do about it, particularly in California, which, as I mentioned, it's kind of an interesting juxtaposition because of the similarities we have with Massachusetts, you know, sides of state notwithstanding, from a education and business perspective, right? Those are the two hubs of innovation. And the short answer is, I think the state, and to maybe not even a lesser extent, the counties and school boards are also really important here. That basically the idea that testing is a critical piece of reopening and doing so safely, and likely will continue to be for younger children through the fall, is a point that can be made at the level of policy, but it's a point also that can be made at the school or school board level. That but it does need to come back up in the sense that I mentioned before, which is in principle in California, because everyone's insurance has to cover their testing, there's not quite the right incentive structure in place. So from either the state or the schools, there needs to be a decision to more effectively use resources and some way in which those savings, because they accrue to all of us either as insurance premium payers or to the state. So I think that's sort of where things are. But these discussions are going on right now, which is, do we need testing? If we reopen, can we do testing? And I think there's the other, big advantage is there's lots of examples of this working. I mean, pretty much many of you may have children in independent schools in the Bay Area, or private schools have basically been doing this for a long time. Universities have done this very successfully since for some time now, and even within, and not pooled testing, but comprehensive testing. Sort of arguing that everyone should have access to that kind of safety, I think, is a reasonable argument, an important argument. And then pooling is the natural follow-on to say, if we can do this for 90% less money, that should be the way to do it.
I'll just follow up briefly by saying, I think that that as John said, these conversations are happening, but my strong suspicion is that everyone is focused so much on vaccinations, appropriately so, that what's going to happen is I don't have any hope that this stuff is going to be implemented in California in the spring. I have a suspicion that come to the summer, once vaccinations start to have gone through, people start to realize that kids aren't vaccinated, that we got to figure out how to open up the schools, that it will start to become an issue. And then, as with always, a huge amount of it has to deal with money. And so to what extent Biden kind of trickles down money or incentivizes it, which at least those conversations are also going on, has an impact. What John and I, though, have definitely learned from this whole thing is it is not like if you have a great idea, it will suddenly happen, particularly when there are so many stakeholders and people with different incentives. And so, but at this point, I'm moderately hopeful that something will happen in the fall. I'm certainly not hopeful that anything will happen in the spring.
There's a question about developing countries. So early on, we both had conversations with some different folks in developing settings about this. I actually think this could be very important for developing countries where this is going to be an ongoing issue. Pooling is being used in some countries. So Ghana has some big pooling initiatives. The issue is the number of PCR machines is pretty constrained relative to the probable disease burden, right? We're not even getting, particularly in the very developing world, that we're not getting good numbers is my strong suspicion. And so I do think this could be very important. And in fact, Paul Gertler, who is another economist in our group, who does a lot of work with health and in developing countries, we've been talking to him about ways to get these ideas deployed, particularly as those countries have years probably until there's any reasonable level of vaccination, that having these kinds of tools and efficiency to use existing infrastructure is probably a more effective approach to doing testing than, for example, having them do antigen testing and things like that, which are cheaper, but they are one-off that way. So there's a question from Mark about UHS. You mean UHS at Berkeley or United Healthcare? I'm guessing he's meaning Berkeley Universal Health Services. So Berkeley, we talked to them about this about a year ago, and other universities did implement comprehensive testing, and they did so eventually moving into pooling mostly by the spring, based in part on some of these ideas. It's, given the vaccination requirements that are coming down, I think, as Ned said, it's unlikely to be critical to getting things going. Would it have been nice to have that investment early on and to have been able to reopen campus using it? I think the answer is yes. And in fact, in part, you heard Ned use the example of dorms. We looked at some of these ideas about ways to effectively collect things on campus. That correlated risk said, don't have a central drop off, have it at the end of the hall. That really was motivated in part by Berkeley.
And I'll just say that from our, like, we talked to Berkeley a while. I think at some point it became clear that testing or no testing, Berkeley was not going to open, given that they just didn't need as many tests. And so the capacity that they currently have, which was about 1,000 tests a day, can sustain what's currently happening on campus, which is not much. Our vision was to open campus and then try to get that up to 20,000 tests a day, of group tests, 20,000 samples with 1,000 tests. But in the fall, it started to become, or in the late summer, it started to become clear that Berkeley was just not going to open. And given that, I think they just didn't need the capacity.
Richard has one question, which I think is, and I touched on this, that who is the right stakeholder here? And I think that's been a huge challenge, that ultimately, because of the externalities of all of this, there's an important role for public policy in the government, both in guidance, but also in paying for it or subsidizing it. And, at the end of the day, optimal policy, in this case, probably looks like a subsidy, which is benchmarked to how much it costs to do pooled testing, but basically says any test that meets certain sensitivity and specificity thresholds, we will reimburse $5 per test, something like that, or maybe $15 fully loaded with the labor to do the testing. And I think that would have been much more effective at motivating and facilitating entry and expansion. That has only just happened partially through the Biden administration. Even organizations, it's an interesting question, and sort of the genesis of this project in part was that Ned and I were doing some independent work with a big company using AI to predict health risk for seniors. And they moved into the testing business for, if you recall, the meat packing companies and had huge outbreaks. And we were working with them on a completely separate AI research project, consulting project. And they said, do you know anything about testing? And we said, no, but an economist came up with this pooling idea 50 plus years ago. Maybe it applies. And that really actually was the impetus for this initially. Those companies, the private interest they had in terms of protecting employee health was not sufficient to implement this kind of surveillance testing. And you've really seen almost no companies, apart from a handful, implement comprehensive testing, in part because labor was either cheap enough, arguably, or because all of their workers were at home. And so,
we're down -1 minute, but I'll just say to John's thing, the most entertaining part about that story is a year ago, we told them, you should be thinking about pool testing, you should be implementing this. And it is just the last week that we had a conversation with them and they said, yeah, we're going to start to do pool testing.
They're going to enter them. So
took a little while, took a little longer than we would have hoped.